about tracheoesophageal fistula with esophageal trachea. So that's the most common type of them. They're many variants. So you have a trachea which kind of splits. You have esophageal fistula, so tracheoesophageal fistula, and then we have an esophageal trachea on top. I'll show you guys a photo to make it sense. So esophageal trachea on top, and then we have a trachea with esophageal fistula over here. That's the main thing over here. There we can see over here. Of course, if they are like this, so whenever they eat, so if they have a trachea, whenever they eat, they're gonna start to like kind of like vomit that out. They're gonna be vomiting out. They're gonna be you're gonna be getting your like whatever your acid secretion is gonna be coming in over here into your respiratory system. So you're gonna be getting choking. You're gonna be getting coughing. It's going to be a big problem, and vomiting with feeds or excessive oral secretion. This is part of vectoral association. So vectoral, what is vectoral? V is vertebral abnormalities, A is anal atresia, C is cardiac abnormalities, T is tracheoesophageal problems, R is rectal problems, L is going to be limb defects. So R, but I messed it up. It's not rectal. It's going to be renal problems. Cardiotrachea. So we're going to be seeing this over here, and then we can come over here. This inability to pass the enteric tube into the stomach. We can see that there's going to be enteric X-ray, so enteric tube coiled into the proximal esophagus. I have gotten two questions over here. So newborn coughing, difficulty feeding, intercostal retraction, 3 hour old, and he's vomiting. What's the next step? We put a nasogastric tube placement. I guess that's going to help over here. And then we're going to come over here. By the way, I want to recap. There are 8 categories when we use nasogastric tube. One is going to be ileus. One is going to be the gastric outer obstruction. And then it's going to be small bowel obstruction. Then we're going to be having intussusception. Okay, those are 4. Then we can also have volvulus. We can also have any patient who's intoxicated. And now we have this tracheoesophageal fistula. There is also one other condition which I am forgetting at the moment. I'll just show it to you guys over here. Peptic ulcer, perforated gastric ulcer disease. So that's one I'm forgetting. All right, so we can see what's the best next step in a symptomatic child with a swallow going in the esophagus, and on X-ray we can do flexmoidal sigmoidoscopy. Guys, if it's like this, if it's vertical, if the coin is like this vertical, that's going to be referring to the esophagus. A trachea, it's going to be a little bit more like it's going to be like this way. So endoscopy is going to be both diagnostic and therapeutic asymptomatic children, but maybe they may observe for 24 hours after digestion. Coins can be sharp. Metal objects are going to be are not toxic versus battery, necessary to prevent and further mucosal damage and esophageal ulceration. Removal is necessary for both symptomatic and asymptomatic patients. All right. So what's the next best step for a child who has swallowed a battery located in the stomach on X-ray? Over here we want to do an endoscopy. Just quickly check it out and quickly take out the battery. Sorry, over here we want to observe them. So if it's going to be anything in the stomach, the batteries are distal to the esophagus, so they can eventually pass out. Okay. So then we come over here to a foreign body. So we can do PA, lateral X-ray, doesn't make a big difference. High risk features, high risk will make 3. Okay, magnets, buttons, and sharp objects. Okay, we can do endoscopy rule. If low risk, we can just observe. If they pass out, if they don't pass out, we can just do endoscopy. So we can do serial X-rays. So yeah, as you mentioned over here, magnets, buttons, sharp items. Sharp items can pin a needle safety pin on the esophagus and the stomach and the proximal amount of the duodenum over here. And then we can see that if the sharp objects are if the sharp objects are distal to the proximal duodenum in an asymptomatic patient, as we can see that and repeat X-ray in 12 to 24 hours, because it may be appropriate because objects are usually excreted uneventfully. Symptoms of esophageal obstruction due to inability to swallow secretion. Symptoms of respiratory compromise is button, battery in the esophagus due to the risk of electrical and chemical injury. Magnets in the esophagus or stomach due to the potential of bowel entrapment or as a result of magnetic attractions across intestinal segments. We can see in case of high risk esophageal, we can see foreign bodies, for example, magnets, the button, batteries, and sharp objects such as the fishbone, immediate endoscopic removal is required to prevent ingestion of more than two magnets, especially if swallowed separately or trapped in bowel via attraction via various segments. This can lead to necrosis, fistulas, and perforations. All right. So guys, we want to come over here to recap. So first of all, guys, you're gonna have tracheoesophageal fistula. Okay, we're gonna have vomiting, choking, and we're gonna be having coughing, all this stuff. We can just do serial x-rays. We can put a chest tube and we can put a nasogastric tube from the nose, put a tube, and we can kind of check it out. Okay, and we want to be vector anomalies: vertebral, anal, cardiac, tracheoesophageal fistula, renal, not renal. It's gonna be renal, not rectal, and it's gonna be limb defects. So then we can have excuse me. And then we can have over here the foreign bodies. So we can have foreign bodies which are going to be you want to make sure that if they are going to be in the esophagus, do endoscopy to remove them. If not in the esophagus, then we can kind of see them. We want to do x-ray. PA or lateral doesn't make a difference. If it's high risk, remove it. What's high risk? Magnets, buttons, sharp objects. If it's going to be low risk, just go and do an x-ray. Just do endoscopy. If it's not transiting, do endoscopy. If there's no transition, then do endoscopy. So we can see over here the sharp objects. So needle, safety pin in the esophagus, stomach. If sharp object is distal to the proximal duodenal and asymptomatic, read x-ray 24 hours because these objects are usually secreted uneventfully. So yeah, we can keep this in mind. All right.